abstract selection, so they were selected to give the oral presentations. And first up is Dr. Booth Dargis. He is a resident in family medicine and was awarded the Trainee First Place Scientific Talk for Excellence in Quality Improvement Research, and will be presenting feasibility of a lifestyle change group medical visit in primary care.
All right. Thank you so much for that introduction, and thanks for having me. I'm really honored to be able to talk with you guys about what we are doing with group medical visits over at Family Medicine. So we're just going to talk about group medical visits in general, the group that we are doing specifically at Family, some of the things that we've been tracking and thinking about, and how we've been evolving those groups over time, the lessons that we've learned, and some ongoing opportunities. So first of all, just very briefly about me, I got really interested in group medical visits for a couple main reasons. My interest in family medicine coming out of medical school was learning the power of lifestyle change in terms of nutrition, activity, stress management, and how that can impact wellness as well as chronic disease. And then my whole life, I've been active and involved in groups and team athletics, and found that I thrive in that environment and do some of my best work with the support of other people. So when I learned about group medical visits, I saw this as a combination of those two things that have been really important to me to bring out to the patient population in general. It was very exciting to me. So group medical visits have been around for more than 30 years. They are in all kinds of different practice settings. There are disease-specific groups, so groups in the literature in asthma, diabetes, things like pulmonary and cardiac rehab for treating chronic diseases. There are also a lot of groups that are just involved in preventive care. So things like pediatric well child visits and prenatal care are the ones that there have been a lot of work on. There are a lot of benefits to group medical care. In the literature, they've been shown that there is no difference in quality of care when you go from a one-on-one visit to a group care. So people in diabetes, for example, are getting the same quality of care that they would in one-on-one. And then you're getting added benefits of being able to be more efficient with your information presentation, teaching diabetes education to 10 people as opposed to one person 10 times is a great efficiency in clinical care. And then the actual group itself, patients form relationships with each other and are able to support each other and teach each other in a way that obviously is not able to be done in a one-on-one setting. Group visits are not for every person, and they're not for every disease. There are people that that may take over a group, or people that won't participate, and they're not going to get the same kind of thing out of a visit that they would out of one-on-one. And then, of course, not every single disease is going to be amenable to a group visit. A group visit for erectile dysfunction maybe is not going to work as well as a group visit for diabetes care. So certain things to think about. And so their group medical visits are really exciting. It's a possibility for us to expand and offer really good care to people in a more efficient way. And so one of the things that we're thinking about over at Family is how can we learn to do these groups in the medical education process. And so in terms of teaching these both in med school and in residency, coming out of training with some skills in facilitating group medical visits is just going to help as these become more and more common, which I think they will. But there are challenges to being involved with and learning how to develop and facilitate your own group visits in residency and in med school. Our schedules change month to month and week to week. And so a visit that's happening weekly or even monthly, it can be hard to predictably be at those groups. And so actually attending them. And then it's more than just you as the clinician or you as the learner that are involved in these groups. There are a lot of other people that help make these group ticks, from medical assistants to nurses to diabetes educators and other folks. And it's hard sometimes to especially thinking about starting a new group, it's hard to corral those resources to start a new project. So what we've been doing at Family Medicine, both of our practice sites at Congress Street and up in Falmouth since 2015, is a lifestyle modification group medical visit. The idea here is that we have been working with groups of patients to work on lifestyle skills and personal development that we know impact markers of chronic disease. And so things like that impact things like weight, BMI, activity levels, blood pressure. And the way that we do this is we have a combination of teaching about nutrition, about exercise, about sleep and stress management and how those benefit everyone, as well as helping people develop individual skills and how to implement and make those changes. So a big cornerstone of skills that we develop for patients are mindfulness skills, being aware of what they are doing and how that's impacting their lives. Then we use things like SMART goals to help them make incremental change over time. So that's making specific, measurable, achievable, relevant and time-sensitive goals that people can make and then ideally accomplish week to week. And something we're really excited about these groups is that they are multidisciplinary, and that's on a number of levels. We have licensed clinical social workers, MD and DO providers, as well as medical assistants and now health educators, and then a lot of learners as well. We have med students, residents, and fellows that are all involved in the both participating in the groups and now as we go forward as well in learning how to facilitate and execute those groups, which we're very excited about. So a little bit of the logistics of our group. They are filled via now an Epic referral. That's new in about the last year or so, which has been great. Basically, we try to get the word out in family medicine among our faculty and residents. And now there's an Epic referral that we can put in for someone who is looking to make lifestyle change, and they get enrolled in these groups. The design is weekly visits. Each visit lasts 2 hours, part of our iterative change. These started out way back in 2015 as a series of 12 visits. That was then shortened to 8, which is most of the analysis that I've done for this talk. But now we've even moved to even shorter groups of 4 weeks, which I'll talk a little bit about. So these have been changing over time. The general structure is a check-in with the provider. That's where kind of the medical visit part comes in. And that happens in the first 15 to 30 minutes with one-on-one meetings. And then the rest of the time is taken up with information and practice and goal setting around various lifestyle interventions. So exercise, nutrition, relaxation techniques. And these are visited week to week. So because we were curious about, how functional and how feasible is a group like this in a primary care setting, we really wanted to look primarily at attendance or people going to these things, and then take a little bit of a look at these modifiable disease risk factors like BMI and blood pressure, and see if we're mostly to make sure that we can track these things. We don't necessarily expect that over the course of 4 or 8 weeks we are going to make a big measurable difference in these. So taking a look at our attendance, looking at 15 series over these 3.5 years, there's a few numbers on here. I think the ones that I would like to highlight is that 2/3 of the way down here, looking at the percentage of those that we enrolled that attended, we're obviously having some dropout, which is to be expected, as well as a big takeaway for me in the bottom right is that we don't see a big difference in the total number of groups that people are attending when we shortened from 12 weeks to an 8-week session. This is a very busy slide that's mostly just demonstrating that we're able to track a lot of these metrics. Again, as I mentioned, it's a pretty short time course that we wouldn't necessarily expect to see changes in blood pressure or BMI. And because these are not disease-specific groups, these are not necessarily people with hypertension or obesity. This is just demonstrating that we can track them. We learned a lot of things, as you can expect, doing these groups over the course of 3 years. I've already mentioned about the duration of the series. It seems that shorter is better. There's better patient and provider engagement and sustaining of energy. We've also learned about group size. As I showed, we are getting dropout for when we sign people up to enrollment. And so it's important to over-recruit for the groups, probably by about 30%. As well, we've learned that kind of the sweet spot for actual number of participants in these groups is in the high single digits. You want enough people so that it's not like a one-on-one encounter, but not so many people that people are able to fade into the background. In terms of financial feasibility, that could probably be a whole nother talk on its own. We're fortunate to be able to do these visits because we're an academic center, but with the numbers, again, in the high single digits, these actually can work in a fee-for-service model. And then having good healing spaces where you have enough space is really important. There are a lot of great things from the provider side in terms of that I've mentioned already: decreased repetition, creating a team environment with their patients and seeing them in a new light, which providers have really enjoyed. And finally, just some last things that we are looking to do going forward. I mentioned that we're now doing a 4-week series. And so there's a lot of work to be done to look at how those are working for patients and providers, looking at long-term outcomes. We always want to provide more learners with these, and part of my talk here is getting the word out about doing these, and we'd love to help spread this out to MMP broadly as group visits. So thank you very much, and happy to take any questions.
It's great, Booth. Thanks. Think logistical sorts of things, time of day, evening versus daytime, as far as who attends, what group of patients, whether it's a Medicare older group or a younger group of, young mothers or whatever. How did you go into deciding, or it depends on the topic, presumably, or how do you approach that?
Yeah, really good question. So these groups were done in, most of them are in the morning. So Thursdays 10 to 12 down at Portland Family Medicine. And that obviously you're eliminating a large chunk of people who have to work during the day. And I think that's an area of growth of trying to get, whether it's earlier in the morning or later in the day, or potentially even weekend time, that then becomes a little bit more of a heavy lift for the providers, right? So that's definitely a barrier that we've come up against. And I think sort of finding people who feel passionate about these and are willing to maybe work off hours would be a place for growth. But yeah, that is something we are not doing, is offering off hours groups.
Hi, were you able to accommodate any non-English speakers, or were they mostly English-speaking groups?
Yeah, great question. These were English-speaking groups only. That is, absolutely a whole nother layer of complexity, and it's something that we do think about, especially, all primary care in Portland obviously is multilingual, and that's definitely a deficit of the model right now.
Last question.
Booth, that was great. I had a question about how you compare what you're doing to cardiac rehab programs that you mentioned in general. And then how do you think about a maintenance program, the way cardiac rehab program uses what they call phase 3 programs? And have you guys had a chance to compare notes about how you're doing what you're doing and what the retention rates and outcomes are?
Really good question. I've not had an opportunity to have those conversations. I would love to going forward. I mentioned, and I'll be brief, that we've now gone to this 4-week model, which is kind of a nice, obviously much shorter. And the goal is that people can then repeat that 4-week session. So there isn't necessarily any structure where you complete the original series and then there's more spaced out maintenance. The way that it's set up right now, people are free to repeat that 4-week series anytime they'd like. I do think that's certainly an opportunity to say, you've done sort of the basic curriculum, now here's group visits spaced at some time as kind of a refresher to come back together. I like that idea.
Great.